So this is an example of a patient who has an intact swallowing function that we would still recommend a PEG placement for. And the reasoning for that is this patient, as you'll see as we progress, has esophageal issues that are more than just significant. There's a complete obstruction in the esophagus. So what you're going to see here is that the swallow function looks quite good. The epiglottic inversion is good. If this was a swallow study that was done without an AP view, it certainly would not be a complete swallow study, and you could make really some recommendations that are beneficial for this patient. But this patient has had an ongoing issue for many months of weight loss and vomiting, and they sent her to the ER and they just placed a PEG tube. They did not do a swallow study. And this is a rural area, so when we went out to actually do the swallow study, I thought, wow, this looks great. This lady should really be eating, and hopefully they solved the vomiting problem. But she reported that they had not, that she was still vomiting. You'll see here all the reflux that starts to come up. So that's what lets me know I really need to look at what's going on in that esophagus. And when we turn this patient, you're going to be quite surprised to see how significant this issue is, and the fact that a PEG tube was placed with no diagnosis of what the issue was. Was it swallowing? Was it, what was it? And even when we turn her, you'll see that it looks, swallow looks fine. There's really no penetration or aspiration on the lateral view. That was very timely. But you're going to see that the dye is backing up almost to the collarbone here. And what I want to do is get down low enough to see, is this a narrowing, what's going on here. And as we get to this level, you'll see that there is an absolute blockage. There's nothing in the stomach. It's absolutely empty. This is a patient where you suspect cancer.
Can you swallow it in
and this has gone on for a while without any diagnosis. And being in a rural area, they thought they had solved the problem by just getting enough nutrition in her by placing the tube directly into her belly. Now, I did recommend that she continue to use that PEG tube, but that she go out immediately to address this issue. So she needs a full upper GI and maybe even a consult for, what is going on here in the esophagus. So a GI consult. And hopefully this will help solve some issues for this lady. And what you're going to see is that as the tertiary contractions that are trying to force this around this blockage are pushing down, you're going to see the dye actually coming out on the screen. So she's just vomiting again. So this is somebody that eating is not going to be pleasurable. So you wouldn't recommend that she take PO intake for pleasure, even though her swallow is functional. So you'll see the dye coming out here. So this is an issue where you're recommending that the patient pursue a PEG tube if she didn't have one already and immediately would need to get it, and that they go in and do some further evaluations about what the issue is here. If they diagnose the cancer and they're going to treat it and radiate it and do chemo and radiation, it'd be nice to have that PEG tube during that process anyway to get through it, because it's pretty hard when you radiate the esophagus. It's you burn those tissues, and the tertiary contractions don't work, and especially at this level, it would be very hard for the patient to eat as they were going through that process. If in fact this is cancer, could just be a little shelf that's in there from the tissues, but because of the significant weight loss and the conditions surrounding this patient, that's what I would suspect. And then I would recommend that they use the PEG and do no oral feedings.